Primary CNS lymphoma is an aggressive brain tumor which typically remains confined to the central nervous system, with rare cases of extra-CNS dissemination. Primary CNS lymphoma is a poor prognosis variant of extranodal non-Hodgkin's lymphoma. It is an aggressive primary brain tumor which remains typically confined to the central nervous system, with rare cases of extra-CNS dissemination. Primary central nervous system lymphoma is a poor prognosis variant of extranodal non-Hodgkin lymphoma. It is an aggressive primary brain tumor which remains typically confined to the central nervous system, with rare cases of extra-CNS dissemination. It accounts for 6.3% of all malignant primary CNS tumors. The median age of diagnosis is 66 years of age. Older patients account for approximately half the cases. The incidence rates have been increasing in age group of greater than 65 years since the 2000s. Greater than 90% of primary CNS lymphomas are diffuse large B-cell lymphomas. T-cell lymphoma, low-grade lymphomas, and Burkitt's lymphoma account for less than 10% of the cases. Histopathology reveals highly proliferative tumor cells in an angiocentric growth pattern diffusely infiltrating the brain. Most tumors express pan-B-cell markers such as CD20, CD19, CD22, and CD79A. By gene expression profiling, primary CNS lymphoma appears to fit into the non-germinal center B-cell-like or activated B-cell-like, which is ABC subtype of diffuse large B-cell lymphoma. There are other molecular features that distinguish primary CNS diffuse large B-cell lymphoma from systemic diffuse large B-cell lymphoma. Genomic analysis of primary CNS lymphoma have demonstrated a high prevalence of MYD88 and CD79B mutations, less frequently CARD11 mutations and other genetic alterations consistent with activation of the B-cell receptor, Toll-like receptor, and NF-kappa B pathways in greater than 90% of cases. Frequent inactivation of CDKN2A has also been noted. These observations have provided insight into potential targets for clinical trials in primary CNS lymphoma. Clinical presentation may be variable and depends on the site of the central nervous system involved. Patients can present with focal neurologic deficits, mental status changes, behavioral changes, signs and symptoms of raised intracranial pressure. Seizures are rare in patients with primary CNS lymphoma but can occur in less than 15% of patients. On brain imaging, a single lesion is commonly seen in 60 to 70% of patients. Multiple lesions are seen in 30 to 40% of patients. The most common sites involved are cerebral hemispheres, corpus callosum, basal ganglia, and thalamus. A gadolinium-enhanced brain MRI is the most sensitive radiographic study for the detection of primary CNS lymphoma. Most patients present with a single brain mass. The mass is typically isointense to hyperintense on T2-weighted MRI sequences and homogeneously enhancing on post-contrast images. Traditionally, surgical resection has not played a role in the treatment of primary CNS lymphoma because of its multifocal and infiltrative nature. The role of surgery is to obtain a diagnosis. Every effort should be made to shorten the duration between clinical presentation and the initiation of treatment. CNS tissue damage due to prolonged lymphoma infiltration is associated with disabling symptoms, loss of autonomy, and poor treatment tolerability with consequent irreversible neurologic impairment. Corticosteroids have lympholytic effects, and so prolonged treatment with corticosteroids before biopsy should be avoided, as this is associated with confounding effects on neuroimaging, delayed and non-diagnostic biopsy, and a higher risk of severe complications during therapy. The International Primary CNS Lymphoma Collaborative Group, or the IPCG, recommends a baseline evaluation with clinical examination, laboratory testing, and extent of disease evaluation, including imaging of the neuraxis, preferably with an MRI or with a CT, CSF studies, eye examination with the slit lamp examination, PET-CT of the body, testicular ultrasound in older men, and a bone marrow biopsy. Age and performance status have been consistently identified to be independently associated with prognosis. Two prognostic scoring systems are used: MSKCC prognostic model, which includes age and performance status with an age cutoff of 50 years, and the IELSG prognostic scoring system, which includes age, performance status, serum LDH, CSF protein, and deep brain involvement. Here, the age cutoff is 60 years of age. Primary CNS lymphoma patients should be stratified according to age, comorbidity, and risk factors to establish a better therapeutic approach. However, age should not be considered as an exclusive parameter when a therapeutic decision must be made. Additionally, performance status scores do not always mirror an individual patient's potential to benefit from treatment in this potentially very responsive cancer. We often see newly diagnosed patients with poor performance status respond and reverse neurologically with early institution of treatment. It is now well established that treatment of newly diagnosed primary CNS lymphoma generally involves two phases: induction and consolidation. The goal of induction therapy is to achieve a complete response. High-dose methotrexate-based polychemotherapy is considered standard of care. The various regimens that have been used include MTRA, RMPVA, Matrix, RMBVPA. Doses of methotrexate of 3 grams per meter square or greater result in therapeutic concentrations in the brain parenchyma and CSF. The goal of consolidation therapy is to reduce the risk of disease recurrence. Various modalities used are whole brain radiation therapy, high-dose chemotherapy and autologous stem cell rescue, and non-myeloablative chemotherapy alone. Despite high initial response rates with high-dose methotrexate-based chemotherapy, most patients with primary CNS lymphoma relapse. Moreover, up to a third of patients have disease that is refractory to high-dose methotrexate. There's no standard of care salvage therapy for relapsed or refractory disease. Various chemotherapies can be tried. High-dose chemotherapy and autologous stem cell rescue, if not administered in the upfront regimen, can also be tried. Whole brain radiation can be used for salvage as well. Targeted agents such as ibrutinib and lenalidomide are included in the NCCN guidelines for relapsed and refractory disease. In general, the responses from most salvage regimens are poor and short-lived, as a result of which clinical trials should be offered. The most frequent complication in long-term survivors is treatment-induced neurotoxicity. This is worse with combination therapy including high-dose methotrexate and whole brain radiation. It is worse in patients over 60 years of age. Patients present with impaired attention, executive function, gait ataxia, and urinary incontinence. It is progressive and irreversible. In summary, primary CNS lymphoma is a distinct disease. Greater than 90% of primary CNS lymphomas are diffuse large B-cell lymphomas. Age and performance status are important prognostic factors. Early diagnosis and institution of therapy is important. High-dose methotrexate-based polychemotherapy improves outcomes. Clinical trials are ongoing with targeted therapies and immunotherapies.